Thank you, respected chairpersons. I'm going to speak on something new which we have started for last 2 to 3 years, and it totally avoids the need of vascular closure devices, and it ambulates the patients immediately after a peripheral vascular procedure. These are the transradial peripheral interventions through transradial approach. And it's very interesting and it's very easy if you learn it properly. It definitely requires a learning curve, which is quite long. Selecting the right patients, having a good idea about the access site, the techniques to get access into the radial artery, the anatomy and the variations in the radial artery and brachial artery, and then a good idea about hemostasis and possible complications. When to consider a patient for transradial approach. If you see the patients of the type of peripheral vascular intervention which we do, because of the proximity of the catheter and to the vessels, especially the subclavian lesions, the vertebral lesions, and sometimes the carotid lesions, these arteries are quite suitable for doing procedures for stenosis as well as aneurysms going through transradial approach. Especially intervening on the renal arteries and mesenteric arteries, that also becomes very simple because these are superiorly directed osteums and the path of the vessel is downgoing. So they are much better engaged and it's much easier to deliver stents and balloons through a transradial approach. And even if you are dealing with proximal iliac artery stenosis and proximal common femoral artery stenosis, we can actually treat them very easily through a transradial approach. Distal to that, because of the limitation of hardware, at present we cannot treat these lesions and we may have to go to a combined approach or a hybrid procedure. Now once we start, we always look at we do an Allen's test and look at the size of the radial artery. The radial artery has to be at least 2 millimeter in diameter to be able to take up a 6 French sheath, and these are the arteries which are then suitable for doing a peripheral vascular intervention. And we always check the Allen's test for seeing the continuity and of the palmar arch, so that even if the radial artery accidentally gets into a problem, the ulnar artery takes care of the supply to the hand. Between choosing the left and the right radial artery approach, the left is easier because it avoids the traversing the aortic arch, and in that case we have a shorter length, better support, and we don't have to go through the complexities of the aortic arch, especially in older person. The candidates which are not suitable are patients who have absent pulses, where the Allen's test is abnormal, and also patients who have Raynaud's disease, or patients who are potentially going to candidates for an AV fistula for a dialysis excess, or who have functioning excess grafts, although many of the failing excess grafts we deal through the radial artery approach. Now, once we puncture, we use a micropuncture set and a pediatric puncture needle, and we are very careful in introducing the needle. We should have anterior punctures and pass in a 014 hydrophilic guide wire, over which we pass in hydrophilic sheath. And once we do that, we always take care that the arteries do not go into spasm. We give a cocktail of diltiazem, nitroglycerin, and heparin, and then the artery is prepared to take in catheters and do our interventions. Again, I told you the left is easier and better to do. It is easier and better to do from the left side. One, because it avoids the problems of the aortic arch, and also accidentally sometimes you have an arterial luxuria. If you go from the right side, you may have very acute angulations and may not be able to reach the desired vessels in the abdominal aorta or the iliac vessels. We go from the radial artery, we take a pigtail catheter or a left Judkin catheter, and then pass up to the aortic arch, into the aorta just beyond the origin of the subclavian artery, and then push in the guide wire. It gets deflected into the descending aorta, and then we pass in the catheter over this wire, and then change it with whatever guide wire we need, and then put a long sheath. If you have to do subclavian angioplasty, we take a 45 centimeter sheath. If you have to do iliacs and renals and mesenteric, we take a 90 centimeter sheath. It's very easy to do any sort of subclavian, carotid, or vertebral intervention. This is one of our interesting patients who had a total occlusion of the left subclavian artery, and somebody tried to open it from below, and there was an injury, and this led to a pseudoaneurysm formation in the same subclavian artery. And we tried to approach from the femoral artery, we could not succeed. Then we went from the radial artery, and this is the angiogram, simultaneous angiogram from femoral and radial approach. And then we tried to pass in a guide wire. It couldn't go from either side, so we subintimally crossed this subclavian lesion and got a re-entry into the ostium of the subclavian artery and into the aorta, and then put a covered stent graft. This is a barred stent graft. And after we actually snared the wire from the femoral and then passed in a stent graft from below, and this is the final completion angiogram. Even for carotids, it's not difficult. Ipsilateral carotids can be hooked through a Siemens catheter. Even the contralateral carotids are hooked through a Siemens catheter. Then we pass in a hydrophilic guide wire and position it into the external carotid artery. Then we advance this diagnostic catheter into the external. Then exchange it with an Emplart's wire, stiff Emplart's wire, and then put a sheath over this. So once we get an access to carotid, we can treat these lesions. This is another case where we had a renal artery stenosis. We dilated with a balloon, then put a renal artery stent. And it's very simple to do these procedures in just 5 to 6 minutes. Similarly, iliac lesions are very easy to cannulate and treat. Common femoral lesions are easy to treat. And we can do it from one side, but if we need to do a kissing stent in the aortic bifurcation, many a times we use both radial and a contralateral femoral approach, where we put one stent from the radial side and one stent from the contralateral femoral side. This is very useful in patients who have hostile aortic bifurcation and also which has very diseased aortic bifurcation, or where we have to treat both common femoral and iliac lesions together. We also use it many times to coil the common femoral arteries, especially before doing an endovascular aortic repair, or also in whenever there is a bleeding or we are doing an aneurysmal repair of the iliac arteries. Complications, I told you, could be spasm, hematoma, compartment syndrome, and sometimes radial artery occlusion. And if we are careful in selecting our patients, this may be unnoticed and the patient may not have much of a problem, but we should be very careful in selecting and treating our patients. There are a lot of advantages, especially in terms of patient acceptance. The hematoma is usually not there if you are careful of the hemostasis. It allows immediate mobilization after a peripheral procedure, which is almost impossible even if you use a device, closer device after the peripheral procedure. It makes intervention possible in aortic occlusions and also severe aortic bifurcation disease. We can also treat contralateral common iliac disease, and it is also used in internal iliac artery coiling. And nowadays, we also use it in treating the dialysis excess fistula, where we go from the radial artery, we open the anastomotic lesion, and then go on distally and open the central venous occlusion. The disadvantages are we are restricted because of the sheath size. The maximum radial artery which it can take is 7 French, and also the lack of availability of long sheaths and long hardware to treat lesions below the common femoral artery level. This is our personal experience of doing peripheral intervention through radial artery approach. We have done last 2-3 years we have started this, and this is 588 procedures, interventions out of the 3,950 interventions which we did in the last 5 years, the peripheral interventions. We have done 35 carotids, which is about 10% of our carotid work which we have done, 105 subclavian angioplasties, 235 renal angioplasties, and about 80 iliac angioplasties. We have done about 26 mesenteric artery stentings.
You have 2 minutes, sir.
So this is our personal experience, and it's now growing, and more procedures in these regions we are doing by a transradial approach. We put a TR band, and after that we mobilize the patient and discharge them on the same day. Thank you very much.
For questions. So can I have the microphone there with the doctor, please?
That was very, very good. The only criticism I've heard by people who do this frequently is that many of the currently available catheters, delivery catheters, are not long enough to go from the arm to get to the mid-abdomen or the renals or into the iliacs on an adult.
I think at least in our population in India, people are not that tall, and most of the patients, I mean, I can go easily up to the iliacs. Sometimes, yes, common femoral could be a problem, but most of them we can go up to the iliacs, especially if you use the left side. If you go from the right side, we lose a lot of length crossing the aortic arch. But from the left side, I could have, I mean, I don't remember any patient I had a problem reaching up to the iliacs. Yes, a little higher, not at the wrist, at least about 2 inches above the wrist level.
Have you had, or is there much of a risk of dislodging stuff into the vertebrals?
Yes, we have to be, that's what, I mean, I am very careful and I teach. We have to be very, very careful because we are crossing, traversing the ostium of the vertebral artery, especially in terms of getting a clot there or making a dissection there or getting an air embolism at that level. So that is, while we are passing, once we are through with a sheath across into the aorta, then it's fine. But till that level, it's very dangerous. And while we are taking out also, we take the same precaution.
Dr. Dhar.
I think the time is almost up. I find it very useful, this radial approach, particularly among the elderly people who are having bleeding from the hepatic artery or gastroduodenal system. Because with the growth of age, this celiac trunk, which is otherwise just a triangular space giving 3 arteries origin, that becomes elongated. And from femoral approach, it becomes very difficult to navigate the catheter up to the mostly their hepatic bleeding or bleeding point. But if we go from the from radial artery, we can go straight into that, and that approach helped me at least on 10 occasions where I had to switch off to the radial, and that could be performed.
Dr. Khanna, do you use brachial approach anytime or not at all?
Brachial approach.
Brachial, I don't find any advantage. Then
No,
it's
no.
better to go through.
It doesn't have any bony structure behind it to press.
Before taking out the sheath, do you put some peripheral vasodilator or dilsem in the sheath?
See, normally if you are doing angioplasty, we always give them a lot of nitroglycerin. So they are adequately vasodilated. When we put in a sheath, we give them a cocktail of diltiazem, nitroglycerin, and heparin. Okay. If there is a spasm, especially while we are pulling out the sheath, then we give them additional nitroglycerin and only pull out the sheath when the spasm is, there is no spasm. Otherwise, it can injure dissect a lot of vessel wall.
Oh, thank you.
Thank you.